All right, thanks, Valeria. And I actually do want to pick up on some of the things that Clemens talked about, because what we're about to present, I think, is a key aspect of several things that Clemens was saying. First of all, this psychosis management pathway is the new norm. It's the standard of care for Vancouver Community MHSU to ensure that we, in a standardized way, diagnose treatment-resistant psychosis and offer clients and families treatment options so that they know what is available and what the best treatment is for their condition. They may not necessarily accept it right off the bat, as we heard in some of your presentations, but we have to make sure they understand that this is appropriate and could be very helpful to them. This psychosis management pathway also, in a sense, reduces barriers for you as the teams in order to help reduce barriers to the clients. And by that, I mean that, obtaining some of the supports that the clients need, as you've been talking about, in order to, access the medications, the laboratory testing, et cetera, follow up with family physicians and specialists. All those barriers have to be overcome with your support. And so we want to give you tools that reduce your barriers to be able to do that. So this pathway and this document really are a culmination and condensation of all the efforts that the project team here has undertaken. And it's really a great example of the collaboration between Vancouver Coastal Health and the Center of Excellence. And finally, Clemens talked about living documents, and that's what this is. It's going to have to be revised and updated in the future. And we'll have to have a process in place for that. So I'm going to turn it now over to Jessica Enyenueva, who's our clinical nurse educator, to introduce this to you. And then Harish and Philip will follow up with their contributions.
Thank you so much, Randall. Okay. Okay, so I don't have any disclosures here or potential conflicts of interest. Any disclosures? Okay. Oops, trying to go further. Here we go. Okay, so here's the psychosis management pathway, and we're just going to do a bit of a walkthrough here. And this really just captures the assessment steps and lists all the tools and resources for clozapine initiation in community, according to which assessment step that you're at. And it's organized into 3 sections. And as you can see on the top right-hand side here, there's a chart guide. So the first part of this pathway here, there's squares with clickable live links that will lead you to the tool or resource that you're looking for. And then the second part, where the circles are the assessment steps. So we have identify a client that may require treatment, optimization of their psychosis, and then providing psychoeducation and motivational interviewing. And then we get into planning and monitoring client during their clozapine titration, and then maintaining the client on clozapine. And so when we go into our first sort of assessment step here in step 1, we have identified a client that may benefit from psychosis treatment optimization, and we identify clients through intake, transfer of care, client and family self-report, client care review every 3 months as recommended by TRIP, and as clinically indicated by a psychiatric assessment. And so when we get a client that we identify, we have a tool that we can use. The screen and manage tool here. So we have a little arrow here to click, and we have our screen and manage tool here. And this has a list of questions, and it contains baseline assessment tools such as the Honos and the Pan Short version. And this tool here really helps determine a care management strategy. And I'm just going to hand over to Harish to kind of touch upon the completion of this tool and the expectations of doing the SAM tool.
Thank you, Jessica. So for most of you, you have seen the SAM tool. SAM is a psychosis screen and manage tool. And the idea was to make sure that our clients have got the right treatment. That is first making sure that they get the first antipsychotic to an adequate dose and they have tried adequately. If it's responded, great job. If it didn't, then we move on to the second antipsychotic. And again, what is an adequate dose? What is an adequate duration? We have talked about this before, but just quickly, mid dose is adequate dose. Adequate duration is 6 weeks, or if in case of depot antipsychotic, it is 6 weeks duration from when the levels reached a therapeutic range. So it's not just about kind of figuring out which patient kind of gets to clozapine or which patient is not adherent to treatment and needs depot injection, but this is a whole pathway of where a patient starts and how they get up to clozapine, or if they respond to clozapine, great, 30 to 60% do. And if they don't, then we get to clozapine resistance, which is need to be dealt by subject matter experts, by which we mean psychiatrists who are working regularly with clozapine resistance, such as in tertiary mental health or BC psychosis, or pharmacists who are working with clozapine on daily basis. I'll hand it back to Jessica here. Thank you, Jessica.
Thank you, Harish. Okay, and so during the TOP Collaborative, the paper pilot version was used, and the screen and manage tool is going to be live on Paris late spring, early summer. So it should be going live pretty soon. So next we have psychoeducation, and so depending on what's been determined as a care management strategy, this is something that's repeated 6 monthly until the client provides consent for depot or clozapine, and this can involve CBT, DBT, motivational interviewing, group therapy, addiction management, involving the client in psychosocial rehab groups, family or support person involvement, the client being involved in peer support groups, and also the client also getting education on psychosis, and the client knowing their triggers, and also learning about like positive coping strategies, in addition to medication education and how to manage side effects. And so what we have here for when a client is thinking about starting clozapine, and when the team is educating the client about what clozapine is, we have resources that you can share to your client. And so we have a video here that we did, a short 3-minute video here that I like to play. Oh, is it here? It looks like it's not here. Oh, here we go. Here's our main characters. Here we are. Now it's gonna play.
Schizophrenia affects 1% of Canadians. That's about 50,000 people. About 1 in 4 people.
This is Clement. It's very hard to hear. Jessica, do you mind if you can?
Okay, sure. Let me just.
There's a button before you say share that says optimize sound.
Okay, let's try this.
Or TRS. TRS is when a person
Okay.
with schizophrenia or
you.
schizoaffective disorder hasn't responded well to at least 2 kinds of antipsychotic medication. Clozapine is an antipsychotic medication for people with treatment-resistant schizophrenia. It works by restoring the balance of the brain's chemicals. Clozapine can help you think clearly, have less harmful thoughts, increase calmness, improve mood, and improve quality of sleep. If you are going to start clozapine, your healthcare team will help you prepare and discuss your care plan.
Your healthcare team will support you throughout your clozapine treatment by meeting with you regularly to see what's working for you and to address any of your concerns. Before starting clozapine, your doctor will complete assessments, including blood work, taking your blood pressure, and a physical examination to see if clozapine treatment is right for you. To prepare for clozapine treatment, you may need to ask for help from a family member, friend, or support worker. Your case manager will discuss your care plan with you. Your plan will include your appointments with your healthcare team, visits to the lab for blood work, and going to the pharmacy to pick up your medications. Please let your case manager know the support you need to help you prepare. For example, if you don't have a regular family physician while you're in clozapine, your case manager can help connect you with one. Every client on clozapine is registered in a clozapine monitoring program, which requires regular blood work. This blood work allows your doctor to monitor the safety and effectiveness of the medication. Taking your medication as prescribed by your doctor, keeping your appointments with your healthcare team, and getting your blood work done on time is very important. Like any other medication, clozapine comes with potential side effects, and some can be serious. Speak to your doctor or case manager about any side effects you may experience. Some common side effects include constipation, blurred vision, dizziness, drooling, weight gain, dry mouth, and drowsiness. Seek immediate medical attention if you experience the following: high fever, chest pain, shortness of breath, intolerable restlessness, severe pain anywhere in your body, confusion, severe stiffness, or seizures.
There are many supports available for you while you are on clozapine. If you have questions or experience any side effects, you can contact your healthcare team or speak with your case manager or doctor during office hours. For after-hours care, you can contact AAC or HealthLink BC, or you can visit an urgent and primary care center. If you require immediate medical attention, call 911 or visit your nearest emergency department. If you or your loved one is living with treatment-resistant schizophrenia, please know you can start clozapine safely in your community with the support of your care team.
Okay, cool. So that was the video. And then next, we have some paper resources that you can provide to the client. So next, we've got the Why Clozapine Now brochure here. So we got the Why Clozapine Now. We have what is clozapine. So it just talks about clozapine and their side effects and where to go when they need help. And next we have the clozapine titration information for a client and their family. And this kind of just organizes all the appointments and that they have, that have the upcoming appointments that they have, and also the information from the team, pharmacy, and their primary care provider. And then next we get into the planning portion of the psychosis management pathway. And this is when we plan the monitoring schedule for blood work, We arrange the pharmacy for the dispense of medication and options. And the team documents a workflow for nursing coverage to monitor for vitals and side effect monitoring. And so the resources that we have here are the criteria for clozapine initiation at VCH and Vancouver sites. So these are all sort of the criteria for at different sites in Vancouver in terms of the criteria to start clozapine at each location. And then we have the decision support tool for clozapine monitoring and management in community. So we have that there here. And then we're going to click on the clozapine start transfer discharge guideline, which organizes the administrative tasks and roles when starting a client on clozapine. So for example, this is when the step 2 of this document, and it just lists the sort of tasks and roles when the client is starting clozapine at a mental health team. Next, we have the information that we share to the GP when a client is going to start clozapine, and this kind of lists all the side effects and their management to send to them. And then I'm going to hand it over to Harish to talk a little bit more about the clozapine weekly and variable titration schedules.
Thank you, Jessica. Just a quick reminder of why we are using weekly titration, that is increasing the dose of clozapine just once a week by in the first week 12.5 milligrams, from second week 25 milligrams. So it's like takes 13 weeks for your patient to be on 300 milligrams of clozapine. We have chosen this as the main way of doing clozapine titration in our community for a number of reasons. This is a lot more slower than what the drug companies or their monologues suggest. And we know that the slower we do, the lesser the side effects, and a lot of patients may achieve therapeutic response midway, or sometimes even at the dose of 50, 75 milligrams. So you can kind of assess this carefully and give them the best possible dose, one. Two, also, it also helps us in the community to kind of do this slowly over a period of time, rather than do it aggressively in 2 weeks, when there may be more side effects and require way more resources. Also, there is good evidence for this from Jacob et al. Study from Stanford Epi Clinic, and also the Ontario mental health teams also use the same regime. Moving on to the next one, which is the variable regime. We have this. We have the variable regime so that if we have a patient who stopped their medication and need to start after the 3rd day, and we need to start, for example, mid-dose, like the patient was on 300 milligrams, now you want to start at 150 milligrams, and you want to do it faster, you want to do it slower, it's up to you. This variable chart gives you the option to kind of vary the speed and the dose as you like. One. Two, again, if you have very young patients or those with medical complications, or those who are older and plus 40, 50 years old and have other medical comorbidities, then you can kind of titrate the dose according to what you see as fit. So that's the purpose that we have this chart there. So these are the kind of 2 things that we are mainly going to use. There's another one that is reflecting the drug company monologues, but we left that for inpatient starts and maybe for very young, healthy patients who can go on increasing the dose every couple of days, but we have not included that here. We'll pass this on back to Jessica.
Thank you, Harish. Okie dokie. And so the next, we have the criteria We get into the monitoring, the clozapine titration resources. So we have the algorithm here. So we got the algorithm, and then next, when we have the document to document all the vitals, and when we are checking for side effects, for signs of infection or signs of myocarditis. And next we have the metabolic monitoring tool, which we're all familiar with here. And then we have the primary care and specialist resource pathway. So in the event that a client is experiencing side effects, this pathway can help determine what kind of medical attention or consult is needed for your client. And so the colors represents the acuity of medical attention required, red representing, immediate medical attention, or orange for urgent medical care, yellow for in-person non-urgent examination, and green is for medical consult only. So we've got sort of that flow sheet portion of this resource pathway here. And the next page lists the contact information of all the resources, including referral forms for cardiology and hematology. And then the description of all the resources that we have here. And so during the monitoring step here, we're addressing side effects and using cross-taper and other antipsychotics as a means, titrating according response to side effects, and then measuring treatment outcomes, such as using HONOS and PANS short version, and consulting a subject matter expert after 8 weeks. And then the last step here is maintaining clients on clozapine and maintaining lists of clients on clozapine registration, having side effect management groups, and having a systemic approach to lab results and prescription. And I'm actually going to get Harish also to kind of touch upon measuring treatment outcomes with the PANS short version, and also when to consult with a subject matter expert.
Thank you, Jessica. Again, just a quick reminder why we need to do the measuring. I think this is something that's laid out very well in the TRIP guideline. It suggests that we do PANS, but again, if you all remember, the Kane et al. Study was mainly on 4 psychotic symptoms, positive symptoms. And we chose an easier way to do this using the shorter version of PANS. So it is ideal to kind of do a PANS short version with your mental state examination. You can dictate it into your case note when you first start the patient on clozapine. And when you reach a therapeutic dose, if the patient is responding, then kind of from there in 6 weeks' time. Or if it is a depot injection, once their plasma level reaches a therapeutic level, 6 weeks from there, again, repeat the PANS. And if the patient has responded, then that's great. You can leave them on that. But if the patient has at least 1 symptom still scoring on the severe range, or at least 2 symptoms in the moderate range, then you say that's treatment resistance, then you move on to clozapine. So the idea of doing this comes from the TRIPS, and also it suggests we do this every 3 months for our patients. And I would say particularly during transitions, and also every time your patient is not doing well, it's a good idea to do that. And then moving on to the other topic that Jessica just mentioned about when to refer to a subject matter expert. I think I mentioned this already with regards to patients who have not responded to clozapine. They're still having score in the range of severe on at least one of the subscales or 2 at moderate level, then we say this is clozapine resistance. And there are a number of pathways to kind of address this, but the clinical evidence is very poor, as was presented by Dr. Honers a while ago. And this is best left to subject matter experts, which is pharmacists who are working regularly with clozapine resistance or physicians working in tertiary care and BC psychosis program. Thank you, Jessica.
Thank you, Harish. Okay, and so just to kind of wrap up here, you can find this psychosis management pathway. This will be available on VCH's documents of clinical care. And as well, we have the top online course available on the Learning Hub if you haven't had all the staff take that course yet. And we have the DST for clozapine initiation community available on SHOP. So I guess now we can open up the floor for any questions you may have. Questions or comments? Okay, will the resource forms be updated with new site locations such as new UPCCs? Yeah, I imagine so. I think we had a new UPCC that opened up at South. And yeah, so that would be updated as well. And we have a comment from Idra, someone with lived experience. I appreciate the step-by-step approach. Thank you. Thanks, Christy. Okay, all right, so I'm gonna turn it over to Larry here.
All right, thank you guys for sharing that. That's great. So if there's any questions, feel free to pop them in the chat as the day progresses. We do have time now, 10 minutes for any questions specific to this presentation or anything that has been shared so far. So if you want to type that in the chat or raise your hand, happy to have you unmute yourself and we can have a bit of a conversation. Any questions around the team presentations from this morning? That would be a time that we can have some questions.
Question from Tracy in there.
Oh, okay. Would this be the time to ask about making blood work easier for clients? Any work in this area? I don't know if anyone wants to answer that one.
Okay, so in terms of blood work, I think before starting a client on clozapine, discussing blood work options before they start, as some clozapine companies offer the point of care device, such as the Pronto device. And also, for example, Life Labs has if they choose not to do Pronto, Life Labs has a mobile app that they could set up and book their appointments on, as well as over the phone. And hopefully that could make accessing their going to blood work easier for that. If you want to, okay.
So thank you for that question. Like Jessica said, you can do those things, and we are still continuing to work on the point of care devices, but at this point, I think it is clearly usable. If you want to use the point of care device, I think there are certain pharmacies that do the Pronto. They actually organize the whole meeting with the client at home once a week to do the blood work. They also deliver the medication on daily basis, and they also do the vitals. So we didn't feel that was necessary to include in this work at this time. Although it's not included, that's still accessible to you. I think a lot of teams are already using that, and that's absolutely fine. And also, I was just going to say, I think this looks very simple, right? It is simple, nothing complex about this. Yet we find it very hard to implement this, because there's so many things that we are dealing with on day-to-day basis. And we end up like, for example, in the review of the charts, we have seen like patients trying 11 different antipsychotics before getting to clozapine. And I've asked some of my colleagues, and they say, I want to kind of find the next best drug. Maybe I will find something. This is like trying chloroquine and COVID, right? You know there is no evidence it's not working, but you know you read somewhere something strange about viral response to chloroquine, and you're still trying that. And it's not worth doing it and sticking with the evidence base. Leave it there.